A 16-year-old male presents with persistent hip pain and a limp. I am showing you an AP pelvis radiograph and a coronal stir magnetic resonance image of the hip. Please describe the findings.
The radiograph demonstrates a well-circumscribed, rounded lytic lesion in the lateral aspect of the capital femoral epiphysis. The stir magnetic resonance image confirms the epiphyseal lesion, but also shows extensive surrounding bone marrow edema throughout the femoral head and neck, and a joint effusion.
What is your primary diagnostic concern?
The findings of a well-defined lytic epiphyseal lesion in a skeletally immature patient, especially with extensive surrounding marrow edema, are highly characteristic of a chondroblastoma.
Where do chondroblastomas classically arise in the skeleton?
They classically arise in the secondary ossification centers, which are the epiphyses or apophyses of long bones, most commonly the proximal femur, distal femur, proximal tibia, and proximal humerus.
Why can the magnetic resonance imaging appearance of a chondroblastoma be misleading or mimic a malignant tumor?
Magnetic resonance imaging shows extensive bone marrow and surrounding soft tissue edema, which can mimic osteomyelitis, Langerhans cell histiocytosis, or an aggressive sarcoma. This reactive edema is a characteristic finding of chondroblastoma, despite it being a benign lesion.
What is the peak age group for this tumor, and does it only occur before physeal closure?
The peak incidence is in the second decade of life. While most common in skeletally immature patients, it can occasionally be diagnosed in adults after physeal closure.
What is the main radiographic differential diagnosis for a lytic epiphyseal lesion in a pediatric patient?
The primary differential is a Brodie's abscess, which is a subacute osteomyelitis. Other differentials include an aneurysmal bone cyst, Langerhans cell histiocytosis, or a giant cell tumor if the physis is closed.
What is the typical histological appearance of a chondroblastoma?
Histology classically shows a sheet-like proliferation of chondroblasts, mononuclear cells with grooved nuclei, and a background of chondroid matrix with a classic chicken wire calcification pattern.
Finally, what are your clinical management recommendations?
I recommend referral to an orthopedic oncologist for surgical curettage and bone grafting of the cavity. Recurrence can occur in 10 to 20% of cases, requiring close radiographic follow-up.